So to start off, American healthcare exists as a unique dichotomy. In some ways, we offer the best healthcare in the world. We have the newest technologies, breakthrough medications, and some of the best doctors in the world. But in other ways, we're really falling short. We have the most expensive healthcare in the world, and we're doing poorly on some key health metrics such as infant mortality. And on top of that, we're one of the only wealthy democracies to not offer universal coverage. So why is that? There's a lot of reasons that could be contributing to this, but one is potentially actually a mistake of history. In World War II, to help support businesses, the government incentivized businesses to offer tax-free health insurance to their employees. And since then, we've been unable to shake that habit. And so that leaves a lot of people who are employed without access to health insurance. So the government has stepped in through the years with a patchwork of fixes, essentially, to try to make sure these large groups of the population could get coverage. And despite that, though, it seems like new leaks are continually springing. So, for instance, though the ACA expanded Medicaid, Supreme Court rulings stepped in and ended up halting some of the expansion to some states. Another instance, in terms of children's health insurance, though it's something that everyone supports and can get behind, it went unfunded for several months this past year because of congressional squabbles. And so healthcare advocates are stuck what feels like in a continuous challenge trying to fill in the gaps of all these new leaks that keep springing, and what ends up being an increasingly complex system. And so that's definitely one of the challenges we're going to have today, and we hope to show you some of the ways in which policy change can happen at multiple different levels, and then hopefully also some of the ways that you guys can be involved in fixing things. So before I move on to my next slide, I want to do just a quick pop quiz. Keeping in mind, like I said earlier, that employer-sponsored health insurance is the modal way that people get insurance, covering about 67% of all kinds of insurance that people have. I want to get a show of hands for how much of all healthcare spending you think the government is paying for. Do you think it's 25%? Can you raise your hand if you think it's about 25% that the government is spending on healthcare? Do you think it's around 50%? Do you think it's around 75%? Okay, so it seems like most people are in the right spin there. Rule number one, the government pays the biggest portion of healthcare. Out of all national spending on healthcare, government is paying for about a total of 45%. And that's made up of the state, local governments, as well as federal government. So why does this matter? It's because the person who has the purse has the power. And so the government has a lot of influence on what kinds of healthcare people can receive and how they're receiving it. The rest of healthcare spending is through households, private business, and other revenues. And a next question, oops, oh, there came the answer. Sorry. Oh, yeah, thanks. Is another pop quiz. Who do you think, what do you think is a bigger part of the federal government's budget? Do you think it's national defense or Medicare? Okay, raise your hand for national defense. Raise your hand for if you think it's about Medicare. Okay, so it's about half and half, which is kind of about right, because as of at least the last numbers we had in 2017, it was also about the same amount, which seems sort of surprising when you think about how often people talk about how expensive national defense is as part of our national budget. Well, Medicare is a huge part too. And it's a part that's going to continue to rise too as the population ages. And an interesting thing to note about Medicare as well is that it's managed in large part and also in an increasing amount by private businesses through Medicare Advantage programs. So though it is a government-funded program, private companies still have a big role to play in how it's influenced. So the next big government program to know about is Medicaid. Medicaid is the health insurance program for the poor. But also, in 1997, it was expanded to include the Children's Health Insurance Program, which is insurance for kids. And so, interestingly, when people talk about Medicaid, I think the modal idea in public is just to think about poor people. But really, in terms of total Medicaid enrollees, most of them are kids. In fact, more kids are enrolled in Medicaid than adults. That's about 43% of all Medicaid enrollments. But on the flip side, since kids are usually pretty healthy, most of Medicaid spending ends up being on adults and the disabled. Another key point to know about Medicaid is that it pays for a lot of nursing homes and other long-term care supports. In fact, in terms of all of the budget paying for long-term care, 40% of that is from Medicaid. So when there's big discussions about cuts towards Medicaid, I think it's an important thing to note that there might be no other options for old people who don't have ECFs to go back to. Another important point about Medicaid is that it is jointly funded through both the federal as well as states to varying degrees. Essentially, the poor states are paying less of the Medicaid, and then more rich states are paying more of their own Medicaid. And because of this joint funding, it allows states to have a bigger role in what sort of benefits they want to offer through Medicaid. So you'll see huge variability from state to state in who's covered by Medicaid as well as what's covered by Medicaid. And the last point in this general overview I want to make is understanding who is in charge of these different government programs. So both Medicaid and Medicare live within CMS, which is on the bottom there, under EMRA. CMS is the Centers for Medicare and Medicaid Services, and it's then overseen by the HHS, the Department for Health and Human Services, which has policies which affects a huge number of Americans. Actually, its policies affect 1 out of every 2 Americans. And it's the umbrella organization for also the CDC, the FDA, the National Institutes of Health, to name many other ones. And so they end up creating a lot of the regulation to explain how these laws are going to be implemented. So they're a huge player in this as well.
Okay, so the next thing we're going to talk about is advocacy avenues. And so what I mean by that is, what ways can your advocacy have an impact on how healthcare is delivered and on healthcare policy? So when you think of policy, what do you think of? How do you think policy is made? Anyone from the audience?
Legislation.
Laws. What else? Regulations. Great. So we're going to go through a couple different avenues. So policy happens at all levels, meaning anywhere from your local hospital, there's policies that affect how you have to practice in your hospital, up through your local government, your city or your county, the state government, and the federal level. Things that happen at the federal level affect everyone in the United States. Then you think about what are the different avenues. So legislative or laws, regulations that determine how laws are actually practiced day to day, judicial, so challenges that go through the court system, and then there's a couple other avenues we'll talk about. So examples here, in terms of laws, at the local level, one example is the city of Philadelphia actually passed a sugary beverage tax. So this is a public health law that was supposed to discourage people from purchasing sodas and other sugary beverages. Tort reform is a statewide example. So if you go state to state, there's laws in place in some states that affect how malpractice affects you as a physician. For example, in Texas, there's pretty heavy tort reform that caps how much a single lawsuit can bring, and also protects physicians in terms of the standard of what type of injury must have occurred for a patient to bring a lawsuit. So that affects how physicians might practice in Texas as compared to other states that have different tort reform laws. At the federal level, most everyone has heard of the Affordable Care Act, and we'll go into some detail about what the Affordable Care Act is and what it does. One that fewer people have heard about is MACRA, or the Medicare Access and Chip Reauthorization Act, which was passed after the Affordable Care Act and has some sweeping changes on how you as a physician will have to practice and how you'll be paid by Medicare. If you remember at the time that the Affordable Care Act was being discussed and was ultimately passed in 2010, there's a lot of discussion in the news and criticism that not everything that was going to happen in the Affordable Care Act was actually detailed in the Act. There was a lot left unknown. Well, it turns out that's how all laws work. All laws are passed with some broad outline of what Congress envisions happening, but it's left to government agencies to write regulations that determine how these laws will actually be practiced. Some examples, at the local level, there may be a law that says that you have to report diseases that you see in your emergency department, but in terms of what diseases and when you'd have to report, like for example, whether you have to report a measles case to your local health department, might be subject to a local regulation. At the state level, there are state-to-state differences in how easy it is to open a new health facility, In some states, they have what's known as a certificate of need. So you have to show need for opening a new health facility or opening a new hospital bed. But in other states like Texas, there's fewer regulations, and so freestanding emergency departments are widely prevalent in those states compared to elsewhere. And that comes down to what are the state regulations about health facilities. The federal level, there's lots of regulations that actually determine how the Affordable Care Act and the MACRA law have been enacted. One example is quality measures that you have to report to Medicare. Those were actually written, so MACRA said Medicare should pay doctors based on quality. Well, the regulation for MACRA is what says what quality measures do you have to actually report. Then there can be challenges to healthcare law. So people can raise legal challenges and say, I don't think that that law that was passed is actually fair or equal, and so the courts will then decide. So for example, lots of states have passed regulations related to reproductive health. Most recently in the news, Iowa passed a law limiting abortion to 6 weeks of age approximately, or when the heart starts beating. That law is already being challenged by a Planned Parenthood lawsuit. So that courts will now have to decide whether or not that law can go into effect. Similarly, at the federal level, many states challenged the Affordable Care Act, and ultimately the legal challenge that went through all the way to the Supreme Court was Medicaid expansion. So the Supreme Court decided that the federal government couldn't force states to expand Medicaid. And as a result, that there's now about 19 states that have not expanded Medicaid, and because of the way the Affordable Care Act was written, it was supposed to provide health care insurance coverage to all, to the very poor through Medicaid, and to the moderately poor through exchange subsidies. But instead, some states, patients may be too rich for Medicaid, but too poor for exchange coverage. And they're left with this coverage gap in the middle. If you think about the hospital where you work, you may be subject to sepsis alerts in your emergency department. Does anyone have those? So that's the result of policies that are written by your medical directors or your hospital administration. At the local level, your city or your county medical society may be active in both lobbying to create local laws as well as creating policies to try to inform politicians about the laws they should pass. Your state medical board has a big role in whether or not you can get a license, how easy it is, how much you have to pay. If a patient makes a complaint about you, how that complaint is handled is variable state to state, depending on your state medical board. And then at the federal level, President Trump has been in the news for lots of different executive orders. One example is, again, coming back to the Affordable Care Act and how it's ultimately being implemented. President Trump issued an executive order saying that the government would no longer pay the subsidies for some of the cost sharing to insurance companies for the exchange programs. And then ACEP, your ACEP committees and your ACEP board create lots of clinical policies, everything from how should a hospital handle patient boarding to ethical issues. So you can go to the ACEP website and see what kind of policies may be protecting you, your practice, or your patients.
All right, so now you know a general overlay of many of the different ways that you can help change policy. Now we're going to talk about some of the legislative landmarks, laws that you need to know as an emergency physician. We're going to go over EMTALA, the Prudent Layperson Standard, ACA, as well as MACRA. So to start up, in 1986, we had the development of EMTALA. And this was created as a response to the problem of patient dumping. Before we had EMTALA, it was a common issue that patients who were unstable and very ill, had no medical insurance, would show up to private hospitals and the ambulances would be turned away to go across town to county hospitals where they would be dumped. And people were decompensating along the way and people were getting hurt. So Congress was able to pass the EMTALA Act, which said that everybody needs to be seen and stabilized regardless of their ability to pay. And EMTALA is really the cornerstone of emergency care and something that we are really proud about as emergency physicians, to be able to see everybody without checking their insurance status first. But the flip side to that is it also creates problems for us as a specialty. Because we don't know if people are going to be able to pay the bills for our services, we have much higher amounts of uncompensated or undercompensated care compared to other specialties. And so in a sense then, what ACEP has referred to EMTALA as is as an unfunded federal mandate. The government said, yes, you have to see them, but didn't really explain how we were going to be paid. And we see commonly in the public as well as for politicians, misunderstanding of the roles that ERs play in the general health system. As George Bush famously said, people have access to healthcare in America. After all, you just go to an emergency room. With not understanding that our job is to acutely stabilize them, but we can't ensure any sort of follow-up.
Another important law to emergency physicians is the prudent layperson standard. So this has been enacted through a series of legislation starting in the mid-90s. And what this means is that an emergency should be defined as how a prudent layperson or your average Joe would define it. So for instance, if someone has chest pain in the middle of the night, a normal average person without medical background, it would be prudent or reasonable for that person to think that chest pain was an emergency, even if the final diagnosis was heartburn. So this is supposed to protect patients so that their insurance will cover their trip to the emergency department for reasonable emergent conditions. Recently there's been a lot in the news, and we'll cover that more later today, about insurance companies trying to deny emergency visits if the final diagnosis was not an emergency. But in theory, this should be protected under the prudent layperson standard. So it was first established in 1994 in an update to the EMTALA legislation that Rachel was just talking about. Then in 1997, it was expanded to everyone on Medicaid through the Balanced Budget Act, and then it was actually the Affordable Care Act in 2010 that said that the prudent layperson standard had to be the standard that applied to all insurance sold to anyone in the United States.
So, of course, the Affordable Care Act, also known as Obamacare, has been subject to a lot of politicking as well as a lot of just emotional debate about it. But it's important to remember what the actual contents of it were. It had two main goals. The first one was coverage expansion, and it mainly did this through Medicaid expansion, increasing the limits that of poverty level that people would be able to get Medicaid at, and it also did this through the individual insurance marketplaces. And the other half of the ACA was patient protections. And I include this picture here on the right of a grad student who was at the Arizona State University when he was diagnosed with stage 4 colon cancer. At that time, before the ACA, the student insurance had lifetime limits of $300,000. Now, as you guys know, cancer treatment is extremely expensive, and so he quickly went over his lifetime limits, leaving him with hundreds of thousands of dollars of bills to pay on top of having stage 4 colon cancer. So he took to Twitter, as you see in that tweet on the bottom. He got into a Twitter war with the Aetna CEO at the time, who basically didn't really understand that his insurance was causing the student to be unable to get the care he needed. And so ultimately, Aetna, after a lot of attention was drawn to this Twitter war, decided they were going to pay for his care. But luckily, now that we have the ACA and some of those patient protections, those sort of things don't continue to happen because we have legislation that says that there's no longer allowed to be any more lifetime limits. Some of the other patient protections were no exclusions for pre-existing conditions, as well as the 10 essential health benefits package, of which emergency care was included, to say that all insurances, if you're providing something called health insurance, you have to provide at least these things, because what would it be if it wasn't covering at least emergency care? So what's the status of this? It's hard to say whether these things are attributable to the ACA or other sort of factors, but some of the things that have happened since then is that we are at historic lows of uninsured. We only have 10% uninsured. Now, this is still like tens of millions of people, but it's the lowest that we've been in a while. Despite that, though, we see that ED visits continue to rise. It's not like people are avoiding the ED care because they have other sorts of care. People with insurance go to the ER. And now, though, because people are coming to the ER with insurance as opposed to having none, we're having a decrease in our uncompensated care in terms of the amounts that hospitals get for insurance companies. And so they've been able to get $7.4 billion back from care for money they would not have had otherwise.
So after the Affordable Care Act, MACRA slipped through with bipartisan support, and because it was bipartisan and much less controversial, a lot fewer people have heard of MACRA as compared to the Affordable Care Act. But what MACRA did is it did two things. It's the Medicare Access and CHIP Reauthorization Act. So it reauthorized CHIP, or Medicaid for children. At the same time, it also changed how Medicare would pay doctors. And so that's the thing that matters most to us as emergency physicians and to our future practice. So there's two tracks that Medicare is going to use to be incentivizing or penalizing doctors in the future. One is MIPS and the other is alternative payment models. So there's no emergency department specific alternative payment model right now. Most emergency physicians are going to be subject to MIPS. And the way you can think about MIPS is basically CMS or Medicare has figured out a way to try to score doctors from 0 to 100 on how well they are doing at providing healthcare. And then based on that score, doctors will either get a penalty payment of up to a 9% reduction eventually in their Medicare payment, or some sort of bonus payment up to a 9% increase. Now of note, this is sort of a zero-sum game. It has to be a balanced budget. So for someone to win 9%, someone else has to lose 9%, which means there's likely going to be a lot more chance of a penalty as compared to actually getting all the way up to the 9% on the bonus side of things. But how do you determine your score? So the MIPS score is made up of 4 components: quality, resource use, improvement activities, and advancing care information. But the important thing for emergency physicians is that it really comes down to quality. 2 of those, resource use and advancing care information, as the regulations written right now, don't apply to emergency medicine, and improvement activities is kind of a checkbox. So it really comes down to quality. Some of the quality measures that emergency physicians have to report currently have to do with, for example, did you use PCARN to avoid head CT in children with low risk head trauma? Did you avoid antibiotics and a viral bronchitis? Just as a couple examples.
So around this time last year, the GOP was in a heated battle to try to repeal and replace the ACA. And after a number of attempts, all those bills eventually failed for different reasons, but some of them got quite far on the pathway towards becoming law. They had different contents, but generally they were all trying to cut healthcare costs, but most of them were at the expense of what Medicaid provided. And ACEP joined other national medical organizations in actively lobbying against some of these bills. As you can see that picture of the Take Action Now, that was an email that you would have gotten if you were on the 911 grassroots network to alert you that these bills were going on. So, and now Trump is known for the quotes, "Nobody knew healthcare could be so complicated." After he thought it'd be a walk in the park, and it ended up not passing. So just to go over some of these bills that died along the way, we had the American Health Care Act, which was going to make care potentially unaffordable for older Americans, and especially in rural areas. That died after it passed the House. The Better Care Reconciliation Act, which would have waived states offering the essential health benefits, as I mentioned earlier, so some people would potentially lose access to emergency care, and that actually passed the Senate, but that died after that. And then the skinny repeal and Cassidy-Graham didn't really have as much traction along the way, so pretty much for now the ACA repeal efforts have fizzled out.
Okay, so that brings us to a quick review of a couple current trends happening in health policy. These are a couple of things that have been happening in terms of healthcare payment, healthcare practice, and reimbursement that you can start thinking about as you get ready for your visit to Capitol Hill on Tuesday. So, as healthcare costs have continued to rise, payers are starting to pass more and more costs on to patients. So the graph we're looking at here is basically over the past decade, what has been the change in out-of-pocket health costs for patients. So the orange line is pretty straight along the bottom. That's what's happened to workers' wages. They've been rising slightly, but pretty slow and steady. At the same time, co-payments, or those flat payments that you have to pay to see a doctor, like for example, you might pay $10 every time you see a clinic visit, or $100 every time you go to the ED, have become less and less popular and less frequent in health plans. And they've been replaced by coinsurance and deductibles. Coinsurance means that instead of paying a flat rate like $10, you have to pay a percent, like 10 to 20% of whatever your final bill is for your treatment. And if you have an ED visit or a couple days in the ICU, 20% can add up pretty quickly. Similarly, deductibles, it's now common that your patients may have at least $1,000, often closer to $2,000, $3,000, $4,000 deductibles. And for a lot of people in the United States, that's effectively like being uninsured. So I know I personally have seen patients come to the emergency department and say that they know they need a surgery or some sort of treatment, but they're unable to get it because they are insured, but their deductible is too high.
Another one of the ways that insurance companies are trying to increase their own profits is by having less people, less providers in a network on their plan. And this is called narrow networks. So, for example, within the ACA, about 30% or so of their plans offer less than 25% of providers in an area on their network. So you'll have a lot of patients who try to see a doctor and then aren't able to find anybody in their surrounding area who's actually part of their plan. And even when patients end up seeing that doctor, they might not even realize until after the fact that that doctor wasn't part of their networks. In fact, about 69% of patients who end up getting one of these bills for somebody who's out of their network didn't realize that that was the case. So what happens next then is that these patients with the out-of-network visits are left with what's called a balance bill, where it's the difference between what the provider is charging and what the insurance company feels like paying, which could be whatever it wants because they're out of network. So consumers are ending up with bills and not knowing how to pay for them.
Another method that payers are using to contain costs is a shift toward value-based care. And what that means is that instead of paying fee-for-service, meaning that you get a fee as a physician for every single service you deliver, regardless of how helpful or non-helpful it was to the patient, instead you get paid some sort of group payment, bundled payment, affordable, accountable care organization payment based on value. Value meaning you deliver the same care for a lower cost, or you deliver the same cost care, but the quality is now been deemed to be higher. So some examples would be bundled payments, capitated payments, but part of the idea is to think about try to align interest across the entire spectrum of care. So how do we think about bringing together primary care physicians to keep patients out of the hospital, emergency physicians who see the patients and interface between the inpatient setting and the primary care setting, and bring the incentives into one lump payment across that entire spectrum of care. What does this mean for us as emergency physicians? Well, it may start to mean that you're asked to be a gatekeeper. So if your hospital system is going to be penalized for a readmission or for any admission for a patient that's receiving some sort of lump sum payment, regardless of the amount of care delivered, you may be asked to send a patient home who otherwise previously you might have admitted under different incentives.
So part of the shift to the value-based payments is an interest in quality. And we've been doing this for a couple decades now in terms of reimbursing hospitals for different quality metrics. And some of these quality metrics make a lot of sense. Things like 30-day readmission or mortality rates for some common issues such as pneumonia, ACS, or CHF. But some of the other quality measures, such as the patient experience surveys, deserve a little bit more inspection. On the hospitalcompare.gov websites, the survey responses are listed online, and the rates at which patients are saying that hospitals are doing these well is also posted. So in this slide, you can see details such as whether patients reported that their bathrooms were always clean is publicly reported as part of the quality for hospitals. And when we think about quality, we have to be really careful to try to determine what we're defining quality as. One of the issues that people have cited with these quality metrics is that the safety net hospitals, which maybe don't have the budgets to have the best bathrooms, are disproportionately doing worse on these patient experience surveys. And as residents, we are all training at these safety net teaching hospitals. So it's of particular interest to us to know how our hospitals are doing. On this slide, I also included a screenshot of the Hospital Compare star rating for a couple of our hospitals that were near the University of Cincinnati. University of Cincinnati is one of our premier emergency medicine residency training programs. It only has 2 out of 5 stars, but its neighboring hospitals have 5 stars.
Maybe it's because their bathroom wasn't clean. Okay, so what have we learned today? And we're going to go into some more depth on a couple of these topics through the rest of the afternoon. But the main take-homes from this quick overview is that the government is paying for a big portion of healthcare, and because it pays for a big portion, it's also has a lot of laws and regulations that determine how healthcare is delivered. There's lots of different avenues besides laws in how you can be active in health policy and in affecting some of these changes that you see. There's some laws that protect patients, ENTALA and the Prudent Layperson's Standard are good examples. And as healthcare costs have been rising, payers are passing more costs onto the patient through deductibles and onto the providers through value-based payments.
So what are the next steps and how can you stay involved? First things first is to sign up for the 911's grassroots network. As I showed on the ACA repeal slide, that would give you updates about any legislation that you definitely need to know about, and it gives you easy links so that you can call your senator or your congressperson to let them know what emergency medicine doctors think about these issues. Next thing is getting involved with your state chapters. This is usually a small and active group of people. Actually, I see some people from my state chapter out here in the crowd, and they're an absolutely wonderful resource for people to mentor you. Another way is through the EMRA Health Policy Committee. We just had a really fantastic meeting with some of the ACEP leaders to learn about quality measures, and there's a lot going on in this committee. You should definitely check that out, as well as ACEP committees. There's some roles for students as well as residents and young physicians to take part in those committees. Another thing is by donating to NEMPAC. NEMPAC is the National Emergency Medicine Political Action Committee. And political action committees really give our specialty a voice on the Hill. It allows us to develop relationships with some of the key decision makers in DC. And as anybody who has done work in DC knows, it's all about relationships. The Give a Shift level, which will let you go to one of the cool events that's going on tonight at the Spy Museum, is $120, but there's other various levels that you can also contribute. And then finally, to learn. It's really important to know what's going on. It's a quickly moving, but also slowly moving policy world. And some ways that you can do that is by checking out podcasts. I'm not somebody who necessarily has all the time in the world to read newspapers, but I certainly have time to fit into my schedule podcasts. We have out in the audience here one of our next speakers, Dan Diamond. He hosts the Pulse Check by Political podcast, and it's stupendous as a way to learn what's going on in DC. Also, the Kaiser Health News Network has one that's called What the Health, and that's also a fun panel-style podcast. And then, of course, PolicyRx.org has a collaboration with EMRA to do policy review articles, and that's another way to learn what's going on in the policy research field. And with that,